You're listening to a podcast of the World Stroke Academy, the educational platform of the World Stroke Organization. Future Stroke Leaders is an initiative of the WSO to develop the technical and research skills of the next generation of stroke professionals. The World Stroke Academy welcomed the contribution of the Future Stroke Leaders members by inviting them to cover specific stroke-related topics in our Pearls Podcast initiative.
Hello everyone and welcome to the Pearls Podcast series from the World Stroke Academy. My name is Aristeidis Katsanos and I'm a vascular neurologist based in Hamilton, Ontario, Canada. I work as a clinician at Hamilton Health Sciences, as a faculty of medicine, as an assistant professor at the McMaster University, and also as an investigator at the Population Health Research Institute. Today we're going to discuss a highly debatable but very important topic, which is the blood pressure control after endovascular thrombectomy. We know that evidence of a large vessel occlusion is reported in up to a third of patients presenting with acute ischemic stroke. The presence of a vessel occlusion is associated with more severe neurological deficits, accounting for more than 60% of total stroke dependency and more than 90% of stroke-related mortality. Endovascular treatment is now the standard of care for acute ischemic stroke patients with a large vessel occlusion, enabling successful recolonization of the occluded intracranial vessel in more than 80% of the cases. Although endovascular thrombectomy has substantially improved functional outcomes and decreased mortality in acute ischemic stroke patients, approximately half of the patients with successful recolonization, defined as reperfusion of more than 50% of the occluded vascular territory, still die or are left severely disabled. Blood pressure management following thrombectomy has been suggested as a potentially modifiable determinant of favorable functional outcomes in this population. While international guidelines propose thresholds of systemic blood pressure of less than 180 mm of mercury and diastolic blood pressure of less than 105 mm of mercury during and for the first 24 hours following thrombectomy, these parameters were in fact arbitrarily adopted from previous intravenous thrombolysis guidelines where real-time confirmation of arterial recolonization is unknown. Evidence from observational studies investigating the association of blood pressure after endovascular thrombectomy with patient outcomes was recently summarized in an individual patient data meta-analysis performed by our group. We found that every 10 mm of mercury increase in the mean systolic blood pressure in the first 24 hours after thrombectomy was associated with a 20% increase in the probability of symptomatic intracranial hemorrhage, a 14% increase in the probability of early neurological deterioration, a 15% increase in the probability of 3-month all-cause mortality, and a 13% decrease in the probability of 3-month favorable functional outcome. We also saw that patients followed distinct blood pressure trajectories. For example, patients with acutely elevated and persistently high blood pressure trajectories had an increased risk of unfavorable functional outcome after adjustment for confounders. These patients also had higher rates of hypertension and a higher risk of intracranial hemorrhage. Interestingly, non-recanalized patients were more likely to be in the higher blood pressure trajectory groups. These findings from observational studies raise the scientific question of whether we can improve patient outcomes by lowering their blood pressure after endovascular thrombectomy. So far, 4 randomized controlled clinical trials have attempted to answer this question by comparing different blood pressure targets in patients undergoing thrombectomy. BP Target was the first trial. It was a multicenter, open-label, randomized controlled trial at 4 academic hospitals in France. The investigators included adult patients with an acute ischemic stroke due to a large vessel occlusion that was successfully treated with endovascular therapy. Successful treatment was defined as a modified thrombolysis in cerebral infarction score of 2B or greater. Patients with an elevated systolic blood pressure after endovascular thrombectomy, which was defined as 130 mm of mercury or higher, were assigned 1-to-1 to either an intensive systolic blood pressure group targeting 100 to 129 mm of mercury or a standard of care systolic blood pressure group targeting 130 to 185 mm of mercury. Patients had to achieve their desired blood pressure targets within 1 hour from randomization and maintain it for 24 hours with intravenous blood pressure lowering treatments if needed. The primary efficacy outcome was intraparenchymal hemorrhage found on CT head scans performed between 24 and 36 hours after the endovascular thrombectomy. The primary safety outcome was the occurrence of hypotension. The BP target trial enrolled 324 patients. Half were allocated to the intensive blood pressure lowering group and half to the standard blood pressure target group. Looking at the patient demographics, first we noticed that 70% of patients had a history of pre-existing hypertension. Another important point of this trial was that the two groups had a mean systolic blood pressure after enrollment of 155 mm of mercury with a standard deviation of 25 mm of mercury. Approximately 45% of enrolled participants had a modified Tiki score of 2B, while around 55% of participants had a modified Tiki score of 3. In the intention to treat analysis, there was no difference in the primary outcome, namely the percentage of patients with intraparenchymal hemorrhage at 24 to 36 hours after thrombectomy. Likewise, no differences were found in the rates of symptomatic intracranial hemorrhage between 24 and 36 hours after thrombectomy or the all-cause mortality in follow-up visits. The mean systolic blood pressure was 128 mm of mercury in the intensive systolic blood pressure group and 138 mm of mercury in the standard systolic blood pressure target group, which means a difference of only 10 mm of mercury between the intervention and the control arm. Hypotensive events occurred in 8% of the patients in the intensive systolic blood pressure group and 3% in the standard systolic blood pressure group. None of the hypotensive events required any intervention, and there was no difference in the neurological related mortality between the two groups. Enchanted 2 was the second randomized controlled clinical trial addressing this question. This trial was conducted in 44 tertiary level hospitals in China and enrolled eligible participants over 80 years old who had persistently elevated systolic blood pressure defined as more than 140 mm of mercury over more than 10 minutes following successful recanalization after endovascular thrombectomy. Patients were randomly assigned 1:1 to an intensive systolic blood pressure target of less than 120 mm of mercury or a less intensive treatment with a systolic blood pressure target between 140 and 180 mm of mercury. Those targets had to be achieved within 1 hour of randomization and sustained for 72 hours post-thrombectomy. The DSMB prematurely terminated the trial after enrollment of 821 participants. The reason for premature termination of the trial was that the early analysis showed a greater likelihood of poor functional outcome in the more intensive treatment group compared to the less intensive treatment group. In addition, the more intensive treatment group also had more early neurological deterioration and major disability at 90 days. However, the trial didn't find any significant differences in the rates of symptomatic intracranial hemorrhage between the two groups or significant differences in the serious adverse events or mortality among groups. Results from the Enchanted 2 trial support that in acute ischemic stroke patients with persistently elevated blood pressure after a successful reperfusion, intensive blood pressure control to a systolic target of less than 120 mm of mercury results in worse functional outcomes and increased rates of neurological deterioration. Given the comparable rates of mortality and symptomatic intracranial hemorrhage, the hypothesis of cerebrovascular compromise from intensive blood pressure lowering has been postulated. The third trial on this topic was recently presented at the International Stroke Conference 2023. BEST2 was a phase 2 prospective randomized open-label blinded endpoint trial to assess the safety and efficacy of blood pressure lowering in patients with successful reperfusion after endovascular thrombectomy. This study took place in the United States and enrolled 120 patients from 3 participating centers. Participants were assigned to 3 different systolic blood pressure targets following endovascular thrombectomy: less or equal to 180 mm of mercury, less than 160 mm of mercury, and less than 140 mm of mercury. Those targets had to be sustained for 24 hours, and nicardipine was used as first-line agent. The primary endpoint of BEST-2 trial was the infarct volume on MRI or CT scan at 36 hours, adjusted for the baseline aspect score. They also assessed the 90-day utility-weighted modified ranking scale score, adjusted for the baseline MRS score. As secondary safety endpoints, they assessed the presence of any intracranial hemorrhage or symptomatic intracranial hemorrhage. The trial enrolled participants from January 2020 to January 2023. For the primary endpoint, no difference in the final infarct volume was found between the three groups. Likewise, no differences in the rates of any intracranial hemorrhage or symptomatic intracranial hemorrhage were found between the three groups. The fourth trial that was completed in this setting was the DETECT trial, performed in our institution. DETECT was a single-center, probe-design, pilot phase trial which aimed to explore the enrollment feasibility of a large-scale trial. Intensive blood pressure management, defined as systolic blood pressure of less than 140 mm of mercury, was compared to standard blood pressure management, defined as systolic blood pressure target of less than 180 mm of mercury after successful endovascular thrombectomy. In this trial, we screened more than 200 patients undergoing endovascular thrombectomy to enroll 30 participants. We found that the natural course of blood pressure normalization following successful recanalization poses a challenge for clinical trials evaluating different blood pressure thresholds post-endovascular thrombectomy. The results from these trials highlight that although increased blood pressure after endovascular thrombectomy has been linked with unfavorable clinical outcomes in observational studies, there is still much uncertainty about the optimal blood pressure target after endovascular thrombectomy. The effect of blood pressure lowering for patients with persistently elevated blood pressure is currently being investigated by other ongoing randomized clinical trials. We need to better understand the pathophysiological mechanisms of early neurological deterioration after endovascular thrombectomy and the cerebral hemodynamics associated with systemic blood pressure control. In addition, we need pragmatic trials with adequate power to test different thresholds for various patient subgroups. For example, the optimal blood pressure may need to take into consideration the patient's baseline blood pressure, the timing and degree of recanalization, the status of collaterals, and the estimated risk of perfusion injury and hemorrhage. Given that blood pressure control after endovascular thrombectomy has the potential to benefit or harm patients, we need definite answers guided by robust evidence that only clinical trials can bring.
Thank you for listening to this podcast. You can find additional stroke education material and resources in our World Stroke Academy website and social media channels.